surgery for in congenital AAD, it's either reducible or irreducible. That's all matter to us. If it's reducible, like this girl, 11-year-old girl, who was wheelchair bound with an os odontoideum, it's what actually quite hyperflexible. It is reducible in hyperextension. You feel very happy about these patients that you might be able to get a good transarticular screw. And so I got a good transarticular screw, nicely fused patient. After 5 years, she came walking. But if you see closely, she's developing a subaxial kyphosis. And I was a little bit worried about that. And maybe we'll discuss this thing in our case discussion. But subaxial kyphosis, if you have an exaggerated lordosis at the C1, C2, is going to be a problem in long term. So try the C1 anterior and posterior arch, if it's parallel to the C2 body, you're safe. So you need to be somewhere inferior to that angle. But if you're more than that angle, then you land up with a subaxial kyphosis of the patient in a long-term follow-up. And make sure that don't just get very happy that it's reducible. Many times it can be hypermobile and lead to something of this nature. Now, irreducible, there is a good old transoral excision and posterior fusion, which used to be a gold standard some 10, 15 years back. But now it's left to be a salvage option. And as Dr. Srivastava said, never write off any surgery. So it's a salvage option now, not a gold standard anymore. For irreducible AADs, you have options like you give some sort of traction, either an awake traction or traction under anesthesia. Get in some sort of release, either an anterior release or a posterior release. And you have to have this occipital cervical fixation for all these cases. So it's irreducible AAD is just like a tussle between an anterior and posterior surgeons. And for all the orthopedic deformity surgeons, it will be similar to scoliosis surgery. While developing scoliosis surgeries, many people would have a debate between anterior release, anterior fixation versus all posterior approach. So we at current juncture, we are similar to that stage where most people are arguing whether we can do this thing all posterior, or some people say that we can do it anterior followed by a posterior occipital cervical fixation. This is a slide from Chituj's presentation that anterior release plus posterior fusion, like what he demonstrated for the earlier case yesterday. Most people will argue that we can do the same thing by posterior, single stage posterior release and fusion, because skull traction under general anesthesia with muscle relaxants, with monitoring gives better reduction in these patients. And I'm going to delve a little bit, pictorial depiction is going to be very simplistic for all of us to understand how it really works, how the process works. So it's going to be a pictorial depiction of Dr. Sharat Chandra's paper in 2019 from AIMS. So the basis of this thing is what you do in the C1 and C2 joint, or the occiput and C2 joint, however deformed or however deformation of that joint is going to be. So it's going to be a distraction by a spacers. You start doing incremental spacers in that joint, which gets the basilar invagination corrected. Then he's developed some methods where you can compress and extend over that, just like you do a T-lift, in order to get a good lordosis, good height cage, and then compress on that and then try to extend. So there are maneuvers where instrumentations where he can compress on the cage and extend on the cage, and he would get most of his corrections for a complex deformity like this. In some cases where he didn't get a good with all this cage, compression and compression behind and extension, he would try to make the dents relocate anteriorly by maneuvers like you saw yesterday, or he's developed special techniques by where you can actually translate the dents anteriorly. So take-home messages, it's going to be a better understanding as we progress along. There have been tremendous surgical advances that have been made, and seems like posterior single-stage surgery is slowly going to win in the long term. But that's not to say that anterior surgery, because it's a simple surgery, and you just have to fix it posteriorly by an occipital cervical fixation. Mind you, this is a steep learning curve with a lot of complications, a lot of important structures. So it has a steep learning curve. Thanks.